Hi, I'm Dr. Malia Swanson. I am a family medicine doctor and menopause specialist, and today we are so lucky to have Dr. Kate Salama here. She is a psychiatrist and specializes in women health and hormones. Will you tell us more about yourself?
Yeah, absolutely. I'm Dr. Kate Salama. I'm a reproductive psychiatrist. So I end up sitting at the intersection between mental health, hormonal fluctuations, and reproductive life transitions. So I treat women who struggle with premenstrual dysphoric disorder, fertility, who are going through pregnancy or postpartum, and then definitely through the perimenopause into menopause transition. And I have my hands in both the conventional and the integrative medical worlds, so combine pharmacotherapy with nutritional guidance, targeted supplementation, more intensive lab testing, and I'm certified in hormone replacement therapy, which is a great tool for women in midlife. And I have a private practice in Denver and see patients as well as on the East Coast virtually, which is where I'm from.
So today we're going to be talking about this intersection between perimenopause and mood disorders and this mood lability that we see in perimenopause and why we see that. Can you tell us, Kate, about why we see mood disorders really rise during perimenopause?
Yeah, absolutely. Yeah, so I think first of all, just to note that it is really staggering kind of how common mental health complications are during perimenopause and menopause. So women have as much of a 2 to 4 times increased risk of mental health distress. There's an increase in psychiatric disorders during this transition. And I believe that SSRIs are prescribed at double the rates in perimenopause as they are in premenopause. So this is huge. And there's many reasons for it. One is biologic and hormonally driven, right? So perimenopause is going to be a time when there's a lot of hormonal fluctuation and erratic hormone levels and an overall decline across the transition in hormones. And so when we think about what hormones are being dysregulated in perimenopause, we're often thinking about the sex hormones. So progesterone is one that starts declining in our 30s. And most women, once they're in their early 40s, are deficient. Progesterone is highly implicated in sleep and in anxiety and in irritability. It acts on the GABA receptor. It's a very calming hormone, and so as women start losing this hormone in their 30s and early 40s, they end up presenting with decreased resilience, anxiety, new panic symptoms, a lot of frustration, intolerance, difficulty with irritability, and definitely new onset sleep difficulties. So a lot of women have inability to fall asleep or stay asleep, and that's often related to that decline in progesterone. And then you also get a decline in estrogen over the menopause transition. And estrogen is interesting because it helps modulate serotonin and dopamine, and so highly implicated in mood. So often when people start losing estrogen or levels are erratic, they're experiencing depression, difficulties with mood regulation, as well as a lot of the cognitive complaints of perimenopause and menopause can be related to estrogen. So I do have a lot of women who experience what they feel like are new onset ADHD symptoms, and that can often be related to these erratic levels of estrogen. And then finally, testosterone is going to decline across the transition as well, and the decline in testosterone can be implicated in poor sleep, poor energy, depression, as well as changes in body composition, which can lead to mood and anxiety difficulties in women. And then separately, a lot of women start struggling with sleep in the menopause transition. And that can be because, like we said, you're losing progesterone. It can be because blood sugar is out of control during the transition. People's thyroids may be more dysregulated. Oftentimes they're having night sweats, which are disrupting sleep. And so when you have chronic poor sleep across this transition, that's elevating risk for depression and anxiety as well. And then a lot of women have a lot of physical symptoms during the menopause transition. This can be weight gain, pain, joint pain, fatigue, lower energy, and all kinds of strange symptoms like frozen shoulder, or difficulties with their teeth and gums. And so people aren't even sure what to attribute to the hormonal changes. They just feel like their body is falling apart, right, during this transition. But you can imagine when someone is all of a sudden gaining weight and fatigued and their body hurts, that's going to increase the risk of depression and anxiety as well. And then finally, there's so many increased stressors during this transition. So this is a time when a lot of women are at the top of their careers. They're also caring for aging parents or parents with medical conditions or parents passing away. Because women are having babies later, they're often still raising young children during the transition. So they're really sandwiched in between caring for their children and for their elderly family members. And it tends to be a time when marital problems might be arising or kind of coming to the surface more, and people just feel kind of disconnected and socially isolated. And a lot of these kind of stress-induced factors increase risk for mental health disorders as well.
You really named all of the things. That's great. Thank you so much for being so comprehensive and talking about all of the reasons why we might see more challenges with mood and how someone might feel in the day-to-day in perimenopause. Now, I'm curious, as women are in perimenopause or approaching perimenopause, how can they determine whether they might be at risk for not just mood lability, but really moving into maybe more clinical anxiety or clinical depression?
Yeah, absolutely. Yeah, so there are several different categories of risk factors that will increase a woman's risk for depression and anxiety during the transition. I would say first, and probably kind of the most heavily predetermined, are going to be your biologic factors, right? And so women who have had any history of depression or anxiety prior to perimenopause do have at least a 2 times risk of experiencing depression or anxiety during this transition. So certainly women who have had any history of hormonal sensitivity in the past are going to be at increased risk. And so this looks like PMS, PMDD, postpartum mood or anxiety difficulties. These women are all at higher risk of having hormonally driven mood and anxiety difficulties in midlife as well. There are other women who may have other medical factors or other hormonal factors kind of driving an increased risk. So often women's thyroids get dysregulated during the transition. That can predispose to anxiety and depression. Other chronic illnesses, autoimmune conditions, high levels of inflammation in the body can all lead to an increased risk as well. I would say for women especially who have had a history of anxiety or depression, hormonal sensitivity, or any chronic medical condition, this is something to be really proactive about and be working with a trusted provider at the very start or even before the transition to prepare and be proactive about your health. And then there are also a lot of psychological or social factors that might make the transition more difficult. So women who tend to have a negative body image or have had a history of disordered eating might struggle with this transition because a lot of women, with the same nutrition and exercise habits do gain weight or their body composition changes. So some women are more predisposed to taking this a little bit harder or having more negative self-image related to this. Women who are high in perfectionist traits, this can be a time period that feels really out of control. And so women who kind of need to be in control or feel, just really out of whack when things with their body aren't going as well, this can be difficult for. And then certainly women who have high stress going on in their lives, whether that's marital conflict, their kids aren't doing well, they have more stress at work or managing aging parents, there's financial stressors. Any of those factors are going to increase risk during the transition and leave women a little bit less resilient to all of the mental health and physical changes.
So it really sounds like self-awareness and knowing kind of what things have looked like for you in the past and how you should support yourself going into perimenopause is really important. If you've struggled with postpartum depression or anxiety, knowing this might be difficult for me going through the mood changes of perimenopause, and maybe I should support myself with people to help me through that season.
Yeah, absolutely. And I think similarly for any woman who I'm working with who's had a history of postpartum depression, we're not addressing it when it comes on for the second or third time. We're addressing it during the pregnancy or even before. There's so many things that you can do proactively to set yourself up to be in a better place if you have increased risk. And I think the same thing is so true of the menopause transition.
Yeah, thanks. So we see that perimenopause can be a really difficult time in terms of managing mood and some of the changes that come from these hormonal changes. What can a woman do to support herself through lifestyle changes through this transition?
Yeah, I think there's a lot that a woman can do to support through lifestyle changes, whether they're just trying to help with mood and mental health, or even to prepare their body for supplemental hormones. I think it's so true that hormones work better going into a body that is healthy and where the foundational pieces are really optimized. So often with my patients, we're talking a lot about nutrition and how to change that or optimize that through this period of hormonal fluctuation. Balanced blood sugar is a huge tenet that we work on in my practice, and one of the reasons for that is because erratic blood sugar can mimic all of the symptoms of anxiety in particular. And so I do find that once we stabilize a woman's blood sugar, her anxiety might naturally decrease and her energy levels are usually much more stable throughout the day and she's sleeping better. So that often looks like coaching women on not eating carbohydrates by themselves, really making sure that we're pairing a lean protein with a healthy fat with a small amount of carbohydrate at each meal and snack, talking about for them what it looks like in terms of, perhaps gentle intermittent fasting at night, but not spacing out meals too far apart during the day. And just really thinking about like, how do they, what are proteins and healthy fats that they like? For a lot of patients, it's even just thinking about, how do I combine that all in a snack and be consistent with that through the day, right? A lot of my patients are grabbing their kids' leftovers in the morning, and that's how they're starting the day, and they're usually starting with a sugar bolus. So it's often starting with breakfast and then kind of working across the day to optimize nutrition. Protein is really, really big in perimenopause and menopause. Often I'm having women track their protein and fiber content across a few days. So what does it look like 3 days of their typical eating? And what we find is most women are really low in protein and fiber content. So we're trying to kind of increase that to a reasonable amount that's sustainable across the day. Fiber really helps with healthy metabolism and hormone detoxification. So that's really important to just kind of increase, usually double in women. I think the average woman's getting 12 grams and we want to be getting about 25 or 30. Right? I think incorporating healthy fats into the diet is super important. I think a lot of women are really scared of fat and might be just eliminating it completely, but it is really healthy for the brain and can help optimize mood if you're putting in kind of those healthy fats into your diet. We want to think about a generally anti-inflammatory diet. There is just an increase in inflammation across the menopause transition, and that can drive a lot of the mental health and physical symptoms. So we really want to cut down on that as much as possible. I think in addition, we want to really think about how much processed food, added sugar, alcohol is in the diet, and are there ways to pare back on that or restrict that, because I think women just don't tolerate alcohol as well during the transition, especially if they're already struggling with mood, anxiety, sleep. It can often be kind of a choice between having a good sleep and drinking that night. So I think just being aware of that and just kind of measuring the connection for yourself between kind of how much of an alcohol burden or processed food burden there is, and then what mood might look like or sleep might look like that day or the next day is really important. Often with my patients, we are talking about targeted supplementation. So I'm typically doing lab work with my patients when they come in for the initial intake so that we can individualize supplementation. But I would say pretty common in the perimenopause, menopause time frame to be taking vitamin D supplementally. Most women are deficient, And that is one of the vitamins that does have good evidence in supporting depression and brain health. So I usually like women to be above 50 when I'm getting a level. For a lot of my patients, we're using supplemental omega-3s to help with brain health and decrease inflammation. Most women just aren't getting the kind of content of omega-3s in fatty fish in their diet that we would want. Often they're using a B vitamin to help with, again, brain health and energy and mood. We might also be supplementing with fiber if they're not able to get in enough fiber through their diet. And there's lots of different supplements that I might use for sleep or anxiety or other mental health complaints. I would say most common is magnesium. Most of my patients are taking that. It can be great for sleep support, for hormonal support, for anxiety as well. Some of my patients just take that at night, but others do it during the day too. And then a lot of my patients will be on things like adaptogens, such as ashwagandha, that can help the body regulate stress, adapt to stress, and can also be really good coverage for mental health distress. In addition to nutrition and supplementation, we're definitely talking about just physical activity and movement, whatever that looks like for you, but with a priority on a little bit less cardio and definitely strength and resistance training during this time period. I think women have to be really careful to kind of continue to build muscle and try to protect their bones as much as possible, with the idea that if you're not doing strength and resistance training, you are likely losing muscle and bone over time, and that's going to lead to more difficulty with, with balance and strength and bone fractures and things like that later in life. So I think if there's anything someone can do in their 30s to prepare for the transition, it would be really starting to do like that 3-4 times a week strength resistance training with progressive overload. And I'd say the last thing we really emphasize in my practice would be everyone having kind of stress reduction practices that work for them and that they can be consistent with. And this doesn't need to look like sitting in meditation for 10 or 30 minutes a day. This can be like taking a walk with your dog, or cooking dinner for your partner, or just being really intentional about getting outside and getting morning sunlight for 10 minutes a day. Or it could be a journaling gratitude practice at the end of the day. But I want my patients to really think about like what is one thing that they can do consistently, really like 5 to 6 days a week, that for them reduces stress and is a place that, if they're feeling dysregulated, they can kind of go to as a reset routine.
What's your favorite stress reduction technique?
Yoga for me.
Yoga.
Yeah.
Mine's hiking.
Yeah. That's awesome. Yeah.
Great. Yeah. That's wonderful.
Yeah.
So tell us, we've talked about all of the lifestyle things that we can do to support our journey through perimenopause. Tell us a little bit about some hormonal
Yeah.
Tell us a little bit about some of the hormone and other pharmacologic means we can use to support ourselves during perimenopause.
Yeah, so I would say there are both kind of traditional psychiatric methods to support a woman during perimenopause, as well as hormonal interventions. And there are studies showing that the combination of the two can be additive or even more helpful than one by itself, right? So from a hormonal viewpoint, often with my perimenopause patients, early perimenopause, I am doing progesterone therapy alone. And so this can look like a bioidentical, kind of an oral micronized progesterone, usually in capsule form, that a patient will take at nighttime. And the reason for this is because, as we talked about earlier, progesterone levels are declining in perimenopause, and especially in the second half of the cycle when you're supposed to be producing progesterone, supplementing with progesterone can help a lot with sleep, anxiety, and irritability. So in my practice, those would be kind of the targets for putting that progesterone supplementation on. And when a woman is still cycling, sometimes we're just doing that the second half of the cycle. In women who cycles are really irregular, or they're getting benefit from progesterone the whole month, we might be doing it continuously as well. In women who don't have a uterus, you can use estrogen on its own. If you have a uterus, you have to use progesterone and estrogen in combination. And estrogen on its own has been shown to have antidepressive benefit as well as cognitive benefit, and there are studies looking at it in augmentation of an antidepressant that show really nice results. So the idea is adding estrogen onto an antidepressant can have this additive antidepressant effect. And most of my patients do have uteruses, so if we're doing hormone replacement and they're later on in the perimenopause time frame or they're having low estrogen symptoms, we are adding estrogen on, and I think that can be really helpful for depression, for sleep, for libido, and for cognitive complaints, as well as a lot of different physical symptoms. In some women, I am supplementing with testosterone either on its own or in addition to the progesterone and estrogen. And I find that women, where I'm thinking about that is women who have low testosterone levels, who might be struggling with libido, even maybe with estrogen and progesterone, their mood is suffering, they're low energy, they are experiencing brain fog. That's a population where that might be a helpful tool. And then for some women, they're taking oral contraceptive pills, right, during perimenopause, and that can be stabilizing too for a subset of women who experience mood dysregulation, and especially women who have PMDD, which exacerbates during perimenopause. If that's been a helpful strategy for them in the past, that might be something that continues to be helpful during this period of erratic hormone fluctuation. And then when I'm thinking about traditional psychiatric interventions for perimenopause, we're using a lot of the same medications that we would use outside of perimenopause. So I'd say if there's an antidepressant that's been effective for you in the past, that's the antidepressant I would typically go to during this transition. I wouldn't say there's an antidepressant that really stands out above the others and being more effective to treat hormonally related mood disorders. All of the SSRIs and SNRIs have pretty good evidence during this time period. I would say Paxil, which is an SSRI, does actually have FDA approval for the treatment of vasomotor symptoms. So if you have a patient who's having a lot of hot flashes and night sweats in addition to mood symptoms, Paxil might be something that you think about. Gabapentin is also a medication that's used a lot in this transition. It's an anti-anxiety medication, but it also can help for sleep and vasomotor symptoms too. But otherwise, I would really think about kind of think about it in the same way as we do outside of the transition. What are we trying to treat? What's the side effect profile of the medication? What do your medication trials look like in the past? And then we're gonna kind of use that information to pick an antidepressant likely that is most helpful for you. Although I would say in my practice, I'm using more and more hormone replacement if we really think that, maybe if there's not a very long mental health history and we think that a lot of the mood changes are related to low or fluctuating hormones.
Yeah, it's fascinating how hormones can affect the brain and how the receptors in the brain are so responsive to estrogen, testosterone, progesterone.
Right.
Yeah.
Right. I think the idea is they're probably misnamed as sex hormones and they should be called brain hormones, and we have so many receptors for estrogen, for example, in the brain.
Thanks for sharing the hormonal options, pharmacologic options outside of hormones. Can you share a bit? So we talked about the perimenopause transition, that transition into menopause, but what can women expect for that last third of their life? What do we see happening when hormones go to that low baseline level? What does mental health look like in that last third of life?
Yeah, it's a good question, and I think a lot of women are relieved to know that usually there is some stabilization of mental health once you've reached menopause compared to the perimenopausal years. So even though hormone levels are low, there's a stabilization in them, and usually what triggers the brain to go haywire or the fluctuation in the hormones and the hormone levels being so erratic. So for most women, once they reach menopause and there's this stable state of hormones, the incidence of psychiatric disorders does decrease back down to the premenopausal state. So for a lot of women, there's a decrease in rates of depression. Anxiety is not as significant. For some, sleep will continue to be a problem, but often the vasomotor symptoms, if that's driving a lot of sleep disruption, will have improved, and so there's not as many triggers for disrupted sleep. And then for a lot of women, once you're in menopause, there is some stabilization of life stressors and transitions too. And it may be more of like kind of this acceptance and comfort and like knowing how to age gracefully. You've done a lot of this hard work during perimenopause. And so for a lot of women, it is a, kind of more grounded, relaxed period of life compared to perimenopause.
Thanks so much for sharing. I appreciate it so much. It's nice to hear about how our hormones are affecting our mood and our overall well-being and how we can support that in the journey. So
yeah,
thank you.
Yeah, thanks for having me.
Yeah.